Sandesh.
Fine, dear. Thank you.
A very good evening to everybody. On behalf of Voice of Healthcare, allow me to extend a very warm welcome to all the speakers and the viewer for today's discussion. As all of us know, the month of October is recognized as Bone and Joint Health Awareness Month. On the same note, Voice of Healthcare, in collaboration with Zydus, has taken an initiative to recognize this by organizing a series of virtual awareness discussions. Now, today, 12th of October is also marked as World Arthritis Day. On the same note, we have this esteemed set of experts with us who shall enlighten us with the common signs, symptoms, do's and don'ts, and maybe lifestyle interventions around arthritis. The topic of today's discussion is understanding arthritis and joint pain. Early treatment and lifestyle changes are key. I'd now like to introduce our speakers for today. We have Dr. Prashant Agarwal with us, who is consultant rheumatologist from Ludhiana. Welcome, Dr. Prashant.
Thank you so much. My pleasure to be
here. Thank you, Dr. Prashant. We have Dr. Naval Mendiratta with us. He's senior consultant rheumatology at Fortis Memorial Research Institute, Gurugram. Welcome, Dr. Naval.
Thanks for the warm welcome.
We have Dr. Sundeep Upadhyaya with us. Sir is professor and senior consultant rheumatology and immunology at Indraprastha Apollo Hospitals, Delhi. Welcome, Dr. Sundeep.
Thank you for having me here.
Thank you. We have Dr. Major General D.S. Bhakuni, who is consultant rheumatology at Manipal Hospital, Dwarka. Welcome, Dr. Bhakuni.
Thank you, Kishore. Thank you.
Thank you. We have Dr. Shruti Bajad with us. She's consultant rheumatologist at Moolchand Hospital, Delhi. Welcome, Dr. Shruti.
Thank you so much. Thank you.
Thank you. We have Dr. Shaloo Bhasin with us. Ma'am is Director Rheumatology at Primus Super Speciality Hospital, Delhi. Welcome, Dr. Shaloo. We have Dr. Narayan with us. Sir is Director, Department of Bone and Joint Surgery at Fortis Hospitals, Bangalore. Welcome, Dr. Narayan.
Hi, good evening.
Good evening, sir. And just to let everybody know, Dr. Narayan would also be moderating this discussion along with sharing his expert views. So without taking any further time, let's begin this discussion. So over to you, Dr. Narayan.
Good evening, everybody. And also welcome to this evening symposium today. And arthritis being such a common problem, which is one of the most common OPD attendants all over the world. And you all know if you are trying to get an appointment from a rheumatologist, it will run like months and months before you can get an appointment. And today you have a great panel of rheumatologists in this forum. And I'm sure they will share their thoughts and their expertise in this field so that they will throw some light on this difficult topic of arthritis, which is such a prevalent problem all over the world. So without wasting much time, I think we'll go straight away to the topic with our eminent faculties today. First question is to Professor Upadhyaya, who has great experience in rheumatology for many years now. The question is, see, the rheumatoid arthritis or any kind of arthritis is such a common problem in the population. But how exactly we recognize them? For example, if somebody has to visit a rheumatologist, when do they should do that? Professor Upadhyaya.
So that's a very important starting question. And the most important features of arthritis is a young lady who's in her 30s or 40s starts to have wrist, hand joint pains, has swelling and stiffness in the joints when she wakes up in the mornings. A young male who has back pain or buttock pain, has difficulty turning sides in the night, gets up very stiff in the morning. So this morning stiffness, night pains, involvement of these joints, hand joints, and sometimes the back, if it's spinal arthritis. These are some of the various manifestations, initial manifestations of arthritis. Many a times, these symptoms are associated with low-grade fever, fatigue, inability to get out of bed and start getting the day together, getting work done in the morning, difficulty making a fist, or bending forwards, picking up objects from the floor. For our Indian populations, difficulty in sitting, squatting on the floor and doing household work. Many a times people will notice swellings of these joints, and in short, inflammation of a joint or several joints, including the spine, is all under the category of arthritis.
Yeah.
So
Thank
they
you.
should go to the doctor, especially a rheumatologist, if some of these symptoms don't get over in a couple of weeks, 10 days, 15 days, and if their your physician, who's their general practitioner or their family doctor, suggests some tests, and if these tests show up as high CRP values or high ESR, factors that tell us about inflammation, then they should certainly go and see a rheumatologist.
Thank you. That is swelling, persistent pain, and with positive blood markers. I think they should see the rheumatologist. That was the summary. Thank you very much, Dr. Upadhyaya. Now you see there are a lot of kind of joint pain and body pain, and I don't know how do you feel in your place. In my place, people with pain everywhere. Sometimes they come and tell me it is naru pain, and some people say arthritis, and some people say something else. So what is the important thing is, are there so many types of arthritis, or if there are many types, what are they, what are the common types? The question to Dr. Agarwal.
That is a very good question, Dr. Narayan. And you highlighted the question very beautifully. The first thing that needs to be noticed is, in case a person is complaining of pain, is it actually arthritis or is there any other cause behind it? Like pain is a very common symptom. A lot of people experience low back pain during their lifetime, but that does not mean that they have gone on to develop inflammatory arthritis in the form of ankylosing spondylitis. So whenever any person with pains come to us, first of all we try to find out whether there is a definite objective evidence of arthritis present in that person or not. By objective evidence of arthritis, we mean that person should have some joint swelling and some joint tenderness or a joint deformity to be present. In case there is objective evidence of arthritis, then we call the patient has got arthritis. The causes for arthritis are different.
But
In
what are the
case
types? What are the types of arthritis for the
I'll be
public to know? Yeah.
But in
Yeah.
case there is no joint swelling or no evidence of objective evidence of joint involvement present, then the causes become altogether different. Now, in case we talk about the causes of arthritis, in common language, there are only three types of arthritis. One lot of people say कि हमें गठिया बाई हो गया है, which I presume they mean rheumatoid arthritis. Then there is a arthritis of old age, which is osteoarthritis, and sometimes people say हमें यूरिया की दर्द है. It is actually not urea. It can be gouty form of arthritis. So in common language, there are only three types of arthritis. But according to modern medicine, there are more than 100 causes of arthritis. In that, there is a category of arthritis which is known as inflammatory arthritis. The commonest one being rheumatoid arthritis, but there are other causes like psoriatic arthritis, SLE, vasculitis, spondyloarthropathies, which can all present with arthritis. Then there can be degenerative arthritis, which tend to affect more in the later age group. The commonest one being osteoarthritis in that. Then there are certain mimics of arthritis also. Like infections, they can also lead on to or mimic like arthritis, or they can present with arthritis. Like hepatitis B infection, hepatitis C infection, that can also present with arthritis. Metabolic causes like hypothyroidism, all these need to be considered.
Is there a way in which you can differentiate between these two? Like the wear and tear arthritis is so common, and your inflammatory is not that common, but it's also second most common probably. Is common people, because treatment is so much different. Is it possible to differentiate between them just by looking at them, or by the science for the common public? I mean, sure, the rheumatologist will differentiate them, but if you
The
can.
most important in differentiating is a good clinical evaluation of the patient. While evaluating the patient, a very key symptom that we ask for is the presence of early morning stiffness. By early morning stiffness, we mean that when the patient gets up in the morning, he is going to find that his or her joints have become very stiff. As the day progresses, the joints tend to ease a bit, and patient finds it easier to carry out the activities of daily living, although the symptoms do not regress completely. Whereas in case of wear and tear arthritis, when they get up in the morning, they tend to feel slightly better, but as the activities progress, because of the wear and tear of the joint, the pain tends to aggravate. Then there can be certain other features of inflammation that can take place in inflammatory arthritis, like a low-grade fever, Dr. Upadhyaya just now told. If there is presence of low-grade fever, that again indicates that there is a presence of inflammation. In case there is weakness, in case there is marked swelling of the joint, and in case there are other inflammatory features in the body, like presence of a rash, weight loss, all of this can indicate that this is an inflammatory arthritis. On investigation, we can find that ESR and CRP are elevated. Along with that, inflammatory arthritis can be associated with certain other markers like rheumatoid factor, anti-CCP antibody, etc.
Yep, thank you. I mean, I think it's such an important thing to differentiate between those two. Whereas you see the wear and tear arthritis elderly has a very, very benign, less problematic course, whereas rheumatoid and other inflammatory can be really, have a lot of consequences to the rest of the body, not just on the joint. And I think they are so important to recognize and get treated by someone like you people in the panel. The next question is, it is to Dr. Mendiratta. Is there an age group? For example, we see a lot of these elderly patients with knee pain, leg pain, etc. But sometimes we get surprised that you get these patients in the young age as well. Is there any age group which is prone to the arthritis or a type of arthritis?
As Dr. Prashant also mentioned, so mostly when we are looking at the inflammatory arthritis group, so there's no particularly age-defined group. You can have kids as young as 3 to 5 years who start having symptoms, and it can go up to any age around 75 to 80 as well. Most common age groups of rheumatoid arthritis, other connective tissue disease like SLE, Sjogren's, we do see in the young females between the 20 to 40 and the childbearing age. And that is the most common age groups, mostly which we have the patients of this connective tissue disease and arthritis. Although world prevalence says it's mostly around 45, 50, I think most of us do see patients between 20 to 40. Same goes with the ankylosing spondylitis group as well. Most patients are between the 20 to 40, but sometimes it can start as early also. So there is a category of arthritis called juvenile idiopathic arthritis, that is the JIA, which is particularly defined in the kids below the age of 16 years. So every time people do ask, arthritis means it's an old age problem, but this is definitely not the case. And because of that lack of awareness, a lot of times people do not get diagnosed and they think that arthritis cannot happen in my kid. And you lose out on a crucial time period during that period. And that's when you start having the joint damages as well. So we do have patients 5 years, 6 years who start with fever, then they start to develop joint pains, rashes. So the arthritis in kids is very different, and that's why a specialist only has to pick it up. And treatment is very essential in these patients because they have the growing bones. Any damage at that time can cripple them for the life throughout.
Yeah. Is it also true that the arthritis can get worse with age? Because we see a lot of these old people with pain rather than younger people.
I think it depends on how well your arthritis is controlled. If your arthritis is well controlled from the start of the illness, then you normally do it in normal life like any other person. If you let the arthritis take its own pace, if the arthritis is getting older with time without a control, then it can trouble you even at the age of 25, 30 as well.
Is there also is there also a male and female distribution in terms of more in women?
Yes,
and
females
men?
have more common autoimmune problems compared to males. Little bit contribution has been given to estrogens, and still there is not a completely differentiating factor that why females get much more of these diseases.
But women have
ankylosing
more
spondylitis and the gout are more prevalent in males. The females do not get too much of the uric acid problems, which again is a problem in our country where every female is being treated for uric acid despite reaching the common cause. So there are certain male predominant, there are certain female predominant.
Yes. I think that's a very important point, what you have just mentioned. So, thank you. The next question is, see, when I was training, people used to tell that this rheumatoid arthritis is not that common in this country. It's all like, probably we didn't have data or whatever. Is it true that, is there any demographic variation, in terms of the incidence of this arthritis world over? And is there similar thing, something called as a seasonal variation? You get these people coming saying that, doctor, because you have come down to the Bangalore, that's why you have pain, that kind of patients. So is it true there is a demographic variation, or is it true that we have a seasonal variation with arthritis? Dr. Bhasin. We can't hear you, Dr. Bhasin. Maybe your mic may be mute. Not yet. It's still off. You may have to change the setting
Hello?
of the mic. Okay now.
Okay, I can't hear now. Hello? Yeah, I'm audible?
You are okay. Okay now. Yeah, okay.
Okay, so it's a very common disorder as compared to the quantity it was thought to be a rare disorder, and the prevalence of the disease is actually 0.5 to 1% globally. And well, definitely there's a demographic pattern. It is seen more in Western Europe, North American countries as compared to Asia, North of Africa, Middle East countries. And it has been observed maximum in individuals of the Native American ancestry. So, and there's a much lower prevalence in African population, probably because of the genetic human leukocyte antigen. And studies have shown the twofold increase in the incidence of the disease in women as compared to the men. And in fact, in women, the disease peaks at a younger age between around 50 to 60, and in men at 75 to 84 age. And the lifetime risk of the disease is actually 3.6% in women, and it is about 1.7% in men. So definitely the disease is quite prevalent, and the incidence is also increased as seen in some studies. And the other part was that the weather, I really don't know directly, but yes, patients clinically, they are more, the disease kind of aggregates during monsoons. So that
Maybe
does play a role.
Yeah. They may feel more stiff because it's cold rather than actual pathology getting worse inside. That's what I feel.
Yeah, so there's no proven fact about that. Right?
Yeah, fantastic. Thank you. And see, in the first session, we have done these 4 questions. And if there is anything, any one of you want to add quickly, you can raise your hand. Of these signs and symptoms only, nothing else for the public. Fantastic. Thank you. And now we'll move on to the next, probably very important topic about the treatment. You want to add something, it looks like, yeah.
Yeah, I just want to say that I would like to tell that whenever, as we're talking about the seasonal variation, I would suggest that patients should not try to change their dose, either taper the dose or during the time when there is a seasonal variation. I've seen when that is done, that causes a flare of the disease. That is personally what I have seen in my clinic. So,
yeah, correct. Thank you.
Thank you.
So, yes, the next is the most important part, the treatment of this difficult issue. I'm sure, you all been enjoying so far as the participants in this course. I'm sure this treatment part is going to be more exciting than what we have done so far. And also, all the faculty understand that, none of you are doctors and we are not going to lecture on the treatment, but it is just going to be simple things in your, the common man, whatever you can understand. That way, only the salient points of treatment. And definitely, this is not going to help you to treat yourself, but it is just the general guidelines. So don't try at home about the treatments, whatever has been discussed now. So the first question is, in a nutshell, in a summary in which, the common people can understand, what are the treatment options available for the arthritic conditions? I'm sure, this probably you can talk like hours and hours, but, if you can summarize in few minutes, it will be fantastic. Dr. Bhakuni.
Yeah, thank you, Dr. Narayan. It's a very, very important topic. Whenever the patient of arthritis comes to us, the first question is, Sir, is it treatable or not? Well,
Yeah.
the answer is yes. Provided if the patient comes to us within 6 weeks or at the most within 6 months, the chances are very high that the patient will be treated. So that is a myth in the amongst the patient that once arthritis is there, it will remain lifelong. Gone are the days when we used to, feel like that, especially we the rheumatologists. That's why the various awareness programs are there so that the patient should report to the rheumatologist at the earliest. So what the first myth is broken, that it is not treatable. It is treatable provided you come early to us. Number two, how long? The second question, how long? Usually for indefinite period. If the patient comes to us late after 6 months or probably after 2 years, almost lifelong, but we do not scare the patient by saying lifelong. We usually tell indefinite, but gradually your medicines will come down provided if you stick to the our advice, as well as whatever we medicine we prescribe, we can bring down the doses, we can stop few medications, we can stop few of the, we can continue one or two medications according to the status of the patient and the patient's disease. Number three, we have a set of drugs or medicines to treat this arthritis, and the topmost amongst that group comes NSAIDs or non-steroidal anti-inflammatory drugs. Although as a rheumatologist we usually hesitate to write NSAIDs because of its hazardous effects on kidneys and stomach and all those, and the general population is also aware, but we cannot keep the patient without with pain. So initially we may give painkillers, so-called painkillers or anti-inflammatory drug to the patient, including the children. Next group of drugs, we call them disease-modifying anti-rheumatic drugs or DMARDs in short. There are various types, we call them conventional, targeted or biologics and all this thing. But if the patient comes to us, we have to start the treatment. Let's start with the treatment of arthritis in children. How do we treat? In children, the first, a tablet or the medicine we give is a painkiller or anti-inflammatory drug to minimize the pain. Next, we start the DMARDs in the form of tablet methotrexate and sulfasalazine sometimes, depending on which kind of arthritis the child is having. Third sort of a group of drug is steroids. Mind you, there is a public, there is a doubt in the public's mind that steroids are very bad. We are not going to take steroid. Doctor, if you give us steroids, we are not going to take it. Please don't do that, because had the steroids been so bad, the factory would have stopped manufacturing them. Doctors would have been sued. How do you write? Why do you write? Because steroids are basically, they are a double-edged weapon. If we use them in unconventional way or in injudicious way, it may harm to the patient. However, with the hands of doctors, we are using them judiciously to break the chain of inflammation in shortest possible period of time. And again, we have to give this drug as a bridge therapy. Now you'll ask me, what is bridge therapy? Because the conventional disease modifying anti-rheumatic drugs, they take minimum 4 weeks, 6 weeks, 8 weeks, at time 10 to 12 weeks. So how can you leave it without pain, with pain during this duration? To cover that duration of action of these actually anti-rheumatic drugs, we have to give you low dose of steroids. We start with 10 or 15 milligram of prednisolone or its substitute in further lower doses. We give it for 10 to 15 days. Thereafter, we try to reduce it, and max to max, we can give you this stuff for 2 to 3 months, except in exceptional cases. So we give low dose steroids. It brings the happiness to the patient. It brings down the inflammation. It brings down the pain, and the patient, especially the children, they are active, and especially the breadwinner of the patient of the family. The breadwinner can go to the work. So that's why the importance of steroids. Please don't have the myth that steroids are bad. They are bad if you use them in higher doses. If you use them in a prolonged, course for the prolonged time, a chance to your rheumatologist to give you this drug, very important drug, judiciously. Third set of drug comes in the form of biologics. Biologics are the small molecule drugs which are very costly, and they are usually by parenteral method, means intramuscular or IV. However, nowadays with the biosimilars or similar drugs and being manufactured in our country, the cost of these drugs have been drastically brought down, so much so that they are affordable. When do we give these biologics? We give these biologics if the disease is severe, very active, not responding to DMARDs, not responding to steroids. We start these biologics and we continue it for some time. Thereafter, we start tapering it, depending on the response of the patient. There are various kind of DMARDs or biologics, but at the end of the month, the cost remains almost same of all the biologics. This much we can assure you that. Next comes the local. Suppose the child comes to us with arthritis. The child, usually their children, they have the involvement of knee joints, ankle joints. They are unable to walk. They are not able to walk. They are not able to go to the school. So what is the remedy? Remedy is local intra-articular steroids. They will not harm. Again, the myth is that some steroids will not take. Why? Because locally, if you give a local steroid injection, it brings down the pain, it brings down the swelling, it brings down the functionality of the children. A similar thing applies to the adult also. But we cannot inject each and every joint. We can usually inject the major joints or one or two or max to max 3 joints at one given time. At one given time. Later on, depending on again situation and the indications. And next question, the further question comes, when we change to or when we add the drug. We usually give 1 or 2 drugs initially, like methotrexate or hydroxychloroquine, for 2 to 3 months. If the patient does not show us any response, we add another drug. If the patient and wait for another 2 to 3 months. If the patient can afford biologics, if the patient cannot afford biologics, then we give another drug. We add another drug. And by the way, nowadays, the kinase inhibitors, one drug known as tofacitinib, it has become very cheap and very affordable. We can give that drug also to the patient, and it acts like a DMARD biologics. In fact, it is a biologic, but in oral form for the general public. Next question comes, when should we stop the treatment? Well, the answer is, if the patient is in remission. Remission means you don't have any painful joints, you don't have any swollen joints, you don't have any early morning stiffness for 6 months. Then we can think of reducing the dose of your various drugs like DMARD, like methotrexate, sulfasalazine, leflunomide, and all these drugs. We reduce the doses, see the patient, monitor the patient. We can stop one medication, we can stop 2 medication, but ultimately we may have to continue 1 or 2 medications lifelong, especially hydroxychloroquine. Next comes the special status like arthritis in pregnancy. Patients ask, sir, can we become pregnant? Yes, of course, but we have to stop your medication 2 to 3 months prior to you conceive. So that is the advice we give. And God is great, I must say. The moment one becomes pregnant, in rheumatoid arthritis especially, all the symptoms, they go away. At the most, we continue hydroxychloroquine, sometimes sulfasalazine. And if, by the way, if the patient's symptoms are aggravating or the patient is not responding to these medications, including small doses of steroids, we can give biologics in the form of injection etanercept. So that provision is also there. We have covered to treat arthritis in each and every situation. Last but not the least, these arthritis patients, rheumatoid arthritis, ankylosing spondylitis, sometimes they involve eye joint. Sometimes we get the patient from eye specialist. Doctor, this patient is having uveitis or scleritis. How will you do? What will you do? We look for some certain investigation, and we treat with biologics known as usually adalimumab or infliximab. What I mean to say that even if there is the involvement of eye or any other organ, we can still treat if the patient comes to us early. That's all I want to say.
It's an extensive topic, and you covered more than what we can remember. Thanks a lot. Now the next question is, you have partially covered that, but we'll also have to add a couple more if we can add. And the question goes to Dr. Bajad. See, like any other system of medicine, we have continuing improvement and innovation in every aspect of the treatment. I'm sure that is happening in the rheumatoid arthritis and other inflammatory arthritic condition as well. I'm sure Dr. Bhakuni has touched upon the biologicals, etc. I'm sure there may be more, And also, if you want to add more in details about this treatment, so that the public can understand in their own way of understanding, if you can keep it to the non-medical word, Dr. Bajad.
Thank you, Dr. Narayan. As you said, Bhakuni sir has almost covered everything. So, for a layman, I don't know what innovation means. For them, it's a part of treatment. So, to go to the basics, for me, how I had seen arthritis as a student and everything, it's a then and now. It's like AC, BC.
Correct.
So, it's before Christ and after Christ. So, like 10 years back, when we entered into this field, so there were very few drugs. And like 20 years back, when someone went to a doctor, they were told, okay, you have arthritis, so you take these painkillers, do some exercise, and you will be okay, or you just live with it. So people have this notion going that they have to live with it, and it's not going to go away, it's untreatable. So my message plainly would be that maybe that time the steroids or maybe painkillers were the drug of choice, but now lot of new drugs have come up, and over 10 years with the onset of these biologicals. What are biological drugs? These are basically copycats who stop our overactive immune system, right? So they are called biologicals because they somehow resemble our body, so they are good for us, they are not bad. So sometimes people get scared, okay, so you are not giving me this biological therapy, you are giving me this biological therapy, so this is something very great and I'll die with it. It's not like that. So it's basically calming down the overactive immune system. How is it different from the earlier drugs, the oral drugs that we have? As sir said, this is parenteral, like it is given in an IV or subcutaneous form. So it's much more active. It treats the patient at a target level. So where the problem starts, it tries to bury that problem. And a lot of people are afraid of this thing, that oh god, these are they are going to suppress our immunity and we will get these lot of infections and this and that. So a general message would be that the biological drugs, they target the specific pathways. So अगर आपको rheumatoid है, so they will target the molecules जो rheumatoid कर रहे हैं. They won't target everything in your body. So don't be scared. Don't be scared of the treatment. Just be scared of the disease. And as I said, the onset of newer drugs, which are popularly known as Jackinibs, which is a very catchy name already. So that can be termed as an oral biologic therapy, because with the other TNF inhibitors and all, since they were parenteral, so a lot of people were wary of it. Like, okay, do I have to take these injections lifelong? So this is an alternative. It has worked very well. It's known as an oral biologic therapy. It works inside the cell and it just blocks the enzyme which alert your immune system. Right? When it is going to go in a hyper mode, so these drugs are going to just stop it. And so these are new drugs. The chances of getting deformities is almost close to nil now. So we used to see, patients who have been having arthritis since 40 years, they come with deformities because options were not there. But with the advent of all the new technology, arthritis is definitely treatable. And with all the knowledge that you have been imparted today, I would just suggest for your treatment, like patient should be a party to this treatment. And, it should be a joint decision between the doctor and the patient, and you should not fear the treatment. If you at all have some fears, please fear the disease and go and see your rheumatologist. So that's all. We have covered everything.
Thank you. That's fantastic. So there are a lot of new inventions and also a lot of new molecules which are promising. One question I wanted to ask personally was that when I was going to the medical school, one of my professors became really famous because he was injecting something called gold. I'm sure this is something gold compound as an immunosuppression which was being used. And it was something like he used to be known in the campus as a gold doctor. Is it still there, or it's been vanished, or any role yet for this kind of treatment, or it's not?
No, sir.
Not.
Since the time I'm in practice, I haven't seen, because gold is
Maybe
fascinating to me also, as you are fascinated by it.
is
But I
Dr.
haven't seen
somebody
anyone.
like Dr. Upadhyaya may be able to throw light on that.
Maybe. But it's no longer used. That I'm aware of.
Doctor,
I
sir, can
want
you
to
quickly 2 minutes?
tell
Yeah. Yeah.
the audience here that when I joined training in 1996, and the first 3 years when I was doing my doctorate, gold molecules were still being used, and that used to be one of the very fancy treatment plans that you could do, but it was
Yeah.
effective. We're still not very sure how it used to work. Technically, it's available in a few countries. You can still go back to it and get hands on it and use it. But given the fact that we now have such
Better
good
drugs.
medicine,
Yeah.
Yes.
we have so many better drugs. So
And
I believe early 2000s it went off the market. I mean, it was no longer used regularly, and
yeah.
most people who have seen it are no longer either no longer practicing, or only the top few of the you know arthritis
Yeah.
specialists in the 70s and 80s.
Yeah.
So
He was
that's
one
how
of
it is.
them. He's still practicing, and I'm sure he's not using gold anymore.
Right.
Uh,
That's
Fantastic. Thank you. And that's one question. Another question which I really wanted to ask was for every, maybe any one of the panelists.
Can
See,
I
the
just
main problem in this country seems to be two things. One is that, see, I've been taking this medicine for months and months and years. So I'm not completely cured of it. So they will find something else. They go to the alternative therapy without mentioning which type and whatever, or the folk remedies or any kind of thing. In fact, I had a lady who is in her 40s. She had migrated from US, where she was being given proper treatment, whatever you have just been describing. But somebody told from here that, if you come back to India, we have this ancient medicine which can cure everything. And she has been told that, you should not eat rice, you should not eat dal, you should not eat ghee, you should not eat nothing. And, her body weight after, all this treatment for years and years with 2 kids was 36 kgs. You don't believe it. I had to counsel her for like an hour, and, almost like everybody was in tears, including me. And she has lost those 3-4 years in this country trying all other medicines with all deformed hands and fingers, and I replaced her knee and hip. It's a very sad story, and she's not uneducated anyway. She's very highly educated and working professional, including in the US. I don't know how you guys from the rheumatology the forum or thing can manage this problem. It is not like they should not do other treatment, but it's really hurts when people are suffering so much just because they have been promised something which is not true. What do you think, Dr. Bhakuni? Yeah, quickly, but Dr. Bhakuni, it's
Yeah,
out of the
I'll not take
syllabus.
much time. We get
Yeah.
lot many patients who switch over to the alternative medicine just because someone is telling them that
Yeah.
allopathic medicines are bad, and
Yeah.
they'll go to a ashram of a famous Baba, and they come back to us after 3-4 months. They go down
E-
south, as you very well said. My patient was 38 kg after 1 year of treatment there.
Same.
They came back. And then next question is, sir, can I take Ayurveda, homeopathy along with allopathy? My standard answer is that, madam, I have just read allopathy. I don't have any knowledge about homeopathy, Ayurveda, Unani, Siddhi. So whatever you do, you feel like you do it. But they try to put the onus on you. Doctor Sahab, lena ke nahi lena? Should I take it or not? I just think it's not my cup of tea. I have not studied this subject. So
I
it's
think
very
it's,
sad. Basically,
yeah.
the other people are to be blamed. Then our next advice.
Anybody want to add a word, Dr. Upadhyaya? Somebody maybe. Is there any effort has been
yes.
done other
So
than these forums, education? Is it
there's
possible to
one way of
make?
approaching
Yeah.
it. Then I would also reach out to everyone who's listening, and there would be lay people,
Yeah.
uh, engineers, uh,
Correct.
historians, IT professionals, for them to understand that if the spectacles work for me, or the watch here runs with a mechanism, can I have an alternative medicine sort of watch, or can I have an alternate type of spectacles that is absolutely different from the physics that's applied here in my case. So I always tell them that scientific medicine is what we practice. Allopathy is just a misnomer for the kind of medicine we practice. And because we have so many parallel streams of medicine, which in many countries we don't have all these many parallel spheres of medicine, and many places there's only one scientific medicine, and everything else is different. So it's a peculiar situation in our country where anything that's taken to be scientific or allopathic is presumed to be a,
Costly
a remnant
side
of the
effect.
British era or a British remnant, and it's anti-Indian, anti-Hindu. That is
This should
extremely
never be
bad.
the case.
I have
Yeah,
to tell
correct.
the audience here that they should log on to the websites that are scientific, that tell us about the truth. You should join groups, academic groups, or patient groups which are in a given situation, like ankylosing spondylitis association or rheumatoid arthritis association. And there you'll get to know what is really happening in the real world and in the honest, good world, rather than people who are out there just to make money and make a name for their own products. They sell it at
I
any
think it's,
cost.
I think it's important that the message should go very clearly that the scientific medicine is a scientific medicine. It can absorb anything which can be proved to be useful. Anything either from any system of medicine, if it is going to be an objectively scientifically can be proven, that medicine will become a scientific medicine. So it is not just the some field of medicine being prescribed. It can be anything if it can be proved. So if it is not proven, kindly don't use. I think it's very important that people should know. So the next question is to Dr. Agarwal, and we have this fad that if you go to the foreign country, probably you will get better treatment. Is it true that we have anything different in this country, or do you have anything latest, very very promising treatment available in the foreign land which is not available in this country at this stage? The question to Dr. Agarwal.
Yes, Dr. Narayan, that is a very important question. Before I exactly answer your question, what I would like to say that in current scenario for rheumatoid arthritis, as Dr. Bhakuni told, we have got multiple different treatment options available. There are multiple different categories of drugs available. Just like even in the category of disease modifying drugs, we have got conventional disease modifying drugs, we have got biological disease modifying drugs, and we have got targeted synthetic disease modifying drugs. So the treatment landscape for rheumatoid arthritis has really transformed. We've got multiple options now available. But despite all of these treatment options that are available, the two critical factors that is still at play is number one is the promptness of treatment. How early the patient gets the treatment, that is going to be the deciding factor later on, that how well the patient is going to do in his life. And second is going to be the approach to treatment. The medicine that we are giving is important, but also is important is that what is the approach going to be as regards the treatment. Not trying to answer your question, all the medicines that are available in the West, same category of medicines are available in our country also, and they are available at a much cheaper rate because we have got biosimilar drugs available like Zydus. They have found out adalimumab, which is available at a much higher cost in the Western world, whereas in our country it is available at a fraction of cost, and a lot of patients can afford it. The difference that we find over here is that a lot of patients have got a lot of misconceptions about medicines and also about injections.
Yep.
So that is one of the difference that we have to deal with while treating the patients over here. The second definitely is the cost of therapy that we have to deal with because a lot of patients cannot afford the medicines. But the advantage that we have over here is that number one, doctors are available more promptly over here. I have got a lot of NRI patients who come to me to consult a rheumatologist in a country like say Canada or in a country like UK. You have to wait at least 6 months. And during those
Yeah.
6 months, the window of opportunity that we are talking of, that is almost gone. And in case you consult a rheumatologist or a specialist, and then again you have a problem, you have to wait for another 6 months. And that is why a lot of NRI patients, they prefer to come over to India to get their treatment because rheumatologist is available very promptly. Secondly, we are not tied down by the limitations of guidelines. Like in the Western countries, they have a specific set of guidelines that first of all, you have to start this medicine. Then after 3 months, they can change over the treatment. After 3 months, they can change over the treatment. Whereas in our country, we can more individualize the treatment according to the patient's need. If a patient is not tolerating a particular drug, we can move on to the next drug much more and deliver much better results to our patients.
Yeah.
I would say the approach to treatment in our country is more individualized, more according to the patient and the availability of doctors. Despite lesser number of doctors being available over here,
And cheaper.
availability of doctors is actually much more prompt over here, and that is why a lot of patients tend to respond much better.
Fantastic.
Now, I'd like to go back to the previous question that you had raised regarding the alternative medicines. That is one problem that we really face from our patients. That a lot of patients tend to be misguided because of various other factors. The so-called alternative medicines in Punjab, what we find is most of the time patients are either using loose medicines or they are using puria. So we actually did some research at our center and we found that in more than 90% of subjects, the alternative medicines were containing steroids in very heavy dose.
Yeah.
And the form of steroid that was contained in them was dexamethasone or betamethasone.
Yeah.
As a qualified doctor, the kind of steroid, in case we have to use, we are either using methylprednisolone or prednisolone in a very low dose. Reason for that is that the half-life of that compound is only 18 hours, not more than that. Dexamethasone and betamethasone, the half-life is 72 to 96 hours. So what that is going to do is, it is going to totally knock out the adrenal glands. Adrenal glands in our body, they are themselves producing corticosteroids. But in case you are taking corticosteroid with such a long half-life, that is going to totally knock out your adrenal glands and you're going to become steroid dependent throughout your life.
Yeah. It's a very indiscriminate use. That is the main problem. Whether
And
it
that's
is required. Yeah.
into our country. I found one over-the-counter alternative medicine being marketed in Hong Kong. And they very clearly wrote the preparation was that it has got dexamethasone and indomethacin index. And that is available over the counter in a country like Hong Kong.
Yeah.
So taking alternative medicines, they've got a lot of disadvantages.
Correct. Thank you. I mean, that's the fantastic. Now, we'll move on to the non-medical aspects of arthritis because we're left with another 15 minutes or so, not long, and we'll keep the answers short and crisp, and so that we'll finish all the questions. So, next question is to Dr. Naval. You see the arthritis, these patients come to the doctors and you scribble some medicines and send them off. But you see, that's only a part of the treatment, correct? So what are those things, how these patients can cope up with this treatment, the expenses and the stress of arthritis, or how do you manage these people, non-medical aspects of the, arthritis?
So the non-medical aspects, one part is the treatment, as you rightly said, and that's where you have to include the exercises and the other part, regime as well. Because a lot of patients who are doing exercises do have a little less pains, less threshold use of the painkillers, and they're able to function and keep the joints healthy. That more would be. Second, as a rheumatologist, we always tend to prolong our visits also for the patients. And after the COVID has come through with the teleconsults, we are able to at least bridge the cost for them for the traveling and other aspects as well. So that at least helps them continue the treatment properly from their home state as well. In visits, we are normally organized at 3 months, 6 months. Most of the rheumatologist prescriptions, if you see, they mostly call patients around then itself. So that does help the patient to continue. Blood test is another thing which patients do feel that every time they have to come, but that's more for the monitoring purpose so that at least we do know the side effects of the medicine, if any changes of the disease are coming through the medicine, so that we are able to figure out that out. So mostly we do not get them down in the hospital as well. So we tell them just do it near your home where it is a little cheaper so you can bring those reports. At least wherever we can, we do try to save the cost for them.
So the technology is helping, and
Technology is
the
definitely
compassionate note. I think that's most important in these kind of chronic diseases, which the least the doctors can do for them. The next question is to Dr. Upadhyaya. I'm sure there are a lot of life skills other than the treatment part. These patients will have to adapt. For example, their family life, the social life, the work, the activities, the recreation, the family, and in so many aspects of the life. I think, in nutshell, how do they cope up, or what is your advice to these patients, who have a chronic arthritis with the disabled, the joints and the flare up of arthritis? Other than the treatment aspect, what do you suggest them how they should live at home from, that some people may be very young and other may be very old, and the approach may be completely different. You may not be able to tell everything, but in a nutshell, can you summarize few
So the
essential
first
tips? Yeah.
Yes, the first few things I glean from the patient is what is the time that they function best. If they are having morning stiffness, if the spine is stiff or the arthritis, tends to make them difficult to work in the mornings, I ask them to start late in the day. I have them, start say an hour later. I encourage them to take a painkiller or a medication that helps them with pain. The first thing they get in the morning, they get up in the morning, and then maybe start to function only an hour after the medicine starts to work or the stiffness wears off, so that the part of the disease which is maximum in the early morning hours is taken care of when the patient is at rest, and get some help from the spouse. I encourage the spouse to prepare breakfast for the patient and the other family members, rather than having the patient get down to making breakfast if morning stiffness is the problem. Then I encourage the family to decide, the evenings out, and especially outings, based on the patient's preferences. If they're going out to say a hill station, or versus they go out to a place where patient can function, can go up and down the stairs maybe, and maybe decide the patient's preference based on his or her ability. So these are some of the uh, important message that I give the patient and the family, that the patient comes first, because musculoskeletal challenges come in the way. As far as their concerns at work and at the workplace related challenges are concerned, I encourage patients to work with their client and their bosses to ensure that on bad days they can work from home, they can do online work, have them take early off if there is problem related to pain and stiffness. I encourage them to have half an hour break during lunchtime, and instead of just having lunch but also doing exercises to the work their joints. Always have them carry emergency medicines like an anti-inflammatory and anti-acidity medicines and the like, so that they don't have to uh, log off
Suffer.
work or go off work just because they're having a bad flare. Uh, Apart from these, I encourage patients who are in midstream of their life and their careers to take up jobs that would be more suitable, or even shift from, say, for example, if they are in a factory setting, from places where they are involved in very heavy major work to something that can be more desk related. So these are some of
Yeah.
these other things that can help based on what the disease
Fantastic.
activity is curtailed.
Thank you. Yeah.
And that's
Fantastic.
not all of them. There are
Yeah,
probably
so
hundreds
many,
of
so much, the
yeah,
occupational, the business,
absolutely.
the mobility aid, so many things. Yeah, thank you.
Mobility
So
aids, using
yeah,
Western commode, avoiding
yeah,
stairs as far
so
as
many.
possible,
Yeah,
using the
yeah.
escalator, so on and
So the
so forth.
next question is to Dr. Bajad. Following question after that will be to Dr. Bhasin out of syllabus, which is going to be, when do you send these patients for surgery, and when do you decide that a patient need a surgery, for example, a joint replacement? That will be next question. Before that, is there anything Dr. Bajad is going to answer, something which people can do to prevent arthritis, for example, in terms of food or activity or some medicines, or you have any suggestions, because a lot of them will be sitting there thinking, how do I prevent arthritis for myself? Yeah, we can't hear you, sorry, we can't hear you. I think we'll may have to remove
Yeah.
that. Yeah,
Yeah.
correct. Good.
So I was just saying that this would be the most interesting question, that there can be done something to prevent arthritis, as it is framed, the question. So, see, you cannot fight with your genes, but then you can tweak them here little bit and there little bit. So there can be certain things which can be done to lessen the impact, which some things are proven, some are not, but there's no harm in trying with them. My first advice to everyone would be to stay at a healthy weight, because what if we are obese, so a lot of it in itself is a pro-inflammatory condition. So if you are at a healthy weight, lot of these aches and pains can be manipulated, or maybe you just get with it. The other thing is, if you suffer from any comorbidity, like if you are diabetic, if you have hypertension or something, whatever, hypothyroidism, please make sure that it is in control so that you save on the collateral damage.
Yeah.
Third thing is exercises. So the muscles, like if it's not required to do 2 hours of strength training, it's just being active. So that is the key. So if you can be a moderately active person, then your bones are much more nourished to handle any kind of injury, or for that matter even arthritis. The fourth point would be, try to avoid the injuries. So if a joint is injured, the secondary changes and all these, the impact of arthritis would be much more in an injured joint.
Yeah.
Last but not the least, if you can quit smoking, because yes, smoking is known to accelerate arthritis. And even the drugs that we use, some studies have shown that if you are an avid smoker, if you're a chain smoker, they work less. So if not, you can quit. Please try to bring it down to the least you can. Other thing is, if you can eat fish, then you can have fish twice a week. I'm a vegetarian, so I would pop a pill, omega-3. Basically they have shown to reduce the inflammation. And not more studies are there, but then even in my practice, I have seen that people who are high on, even in diet of omega-3, it's good with them. The course is good with them.
Yeah.
And
Thank you.
If you have a family history, I just want to point out one thing, that if you have a family history, if your mother has it or if your sister has it, so as you can share the dresses, you can share the genes also, and you may get rheumatoid. So be on a watch for that. And if you have arthritis, then please read and educate yourself, and just not read on Google. Go on good sites and get a scientific information.
Fantastic.
I think that's all you can do to tweak your genes and smoothen your course.
Thank you. Next is to Dr. Bhasin, and I have just told already the question. We can't hear you. It must be mute. You must be mute. You are on mute. Unmute the screen. Unmute.
I've done that. Yeah. You can hear me now?
Yeah, perfect.
Okay, so I have a very simple, thing which I follow. If a patient who is otherwise doing all fine and only his knees are paining and it is a mechanical pain, and so I tell the patient that with so many drugs, you are doing fine always, but your knees are not getting better, you need to go for surgery. And I mean, my decision is always more clinical, and I leave rest on the orthopedician. I send the patient to the orthopedician and let them decide whether. But most of the time surgery is required, because otherwise all the other joints are questioned. It's only the knees which is troubling. And I've seen patients, they stop going out, they stop doing their routine work when it is affecting your daily routine, and it's causing a hindrance to your life. You should go. But the second thing, another thing I've noticed is, I always tell the patient that the patient should be first convinced. You can't just force a patient into surgery, because then after that the physiotherapy and the initial 2 or 3 months, they are important. So the patient should have that willpower, then only you should go for surgery. I think that's a very simple. And for young patients, definitely, like I had a young girl who had severe deformity of the hands. So for her, definitely I told her to go in for hand surgery, because she was in 10th class, there was difficulty in writing and all, despite the disease now in remission, but the damage had already been done. So in those cases, again, surgery is required. So I think that is more of a clinical.
Fantastic. Yeah, thank you. So there are 2 types of surgeries used to be, these synovectomies and deformity correction, etc. Thanks to the rheumatologists and the advancement of treatment, we don't even do them nowadays. Completely stopped. Whereas the joint replacements, everybody knows, to improve the quality of life. There is nothing like them. In fact, the hip replacement was called the operation of the century. Say they give a lot and fantastic quality of life, but they are needed only in a small percentage of people, who cannot be managed with otherwise. So the last question of the day, we are almost running out of time, is to Dr. Bhakuni. Is there any nice food these patients can eat so that their arthritic condition is not getting worse, or they can have some relief just with the food, or is something which can help them in terms of their daily food? Dr. Bhakuni. Is he around? Dr. Bhakuni? Hello? Maybe Doctor, quickly, anybody can answer two lines, what they should be eating. Dr. Upadhyaya. Yeah.
So eat everything. Other than tobacco, eat everything.
Fantastic.
And if possible, use dahi, curds, nimbu, vitamin C, fresh fruits, vegetables, salads,
Fantastic.
veg, non-veg, everything.
Be normal. Be normal. I think, if you eat normal, be normal, you feel normal.
What is
Rather
good for
than
your wife or your husband is good for you. What is good for your child is good for you.
half of the people don't eat aloo, other people don't eat dal in this country. Just, they think it's all vayu, which is causing all this problem. Anyway, fantastic. And it was great that, we had a lot of questions, common questions, which is in the mind of the common public in this country we have answered. I'm sure, these kind of programs, if we do more and more in the future, probably, I'm sure, that will reach more and more people, and we may be able to educate these people and try to help them out of this, the chronic inflammatory disease condition in the body. I would hand over with thanks to all the speakers today. You all have done a fantastic job. I'll hand over to the organizers if there's anything else they have to add. It is little 2 minutes over 7 o'clock. Thank you very much. Thank you, panel.
Thank you.
Thank you very much.